Thank you for joining us. If you're in the eastern part of the state, we have a snowy day today, so at least we're not going to get hammered like Boston. So I want to thank everyone for joining us. This presentation by Dr. Cherpes, who is with the Office of Developmental Programs, is just a part of our COVID-19 Health Disparities Grant that we have through the Pennsylvania Department of Health. I forgot their name for a second, and which is also a grant of the CDC. So we are working on health disparities throughout this pandemic as it relates to people, marginalized communities, including people with disabilities, people of different colors and cultures, and people living in rural health. I'm not going to take all the time because Dr. Cherpes has a great presentation ready for us. Just to give you an introduction, Dr. Cherpes is the medical director for the Office of Developmental Programs, Department of Human Service of the Commonwealth of Pennsylvania. He is board certified in general psychiatry, as well as child and adolescent psychiatry. Dr. Cherpes' clinical and research and educational efforts have been devoted to addressing the healthcare needs of people with intellectual and developmental disabilities across the lifespan. Prior to joining ODP in 2015, he served as the Director of Behavioral Health and Director of the Center for Prader-Willi Syndrome of the Children's Institute of Pittsburgh, the Medical Director for Child, Adolescent, and Developmental Disability Services at Allegheny East MHMR, and is the former medical director of 2 of the state's healthcare quality units. And just to give a personal note, this has been a long 2 years for all of us, but there has been one constant force in our work, and that has been Dr. Cherpes. And I would like to personally thank him on behalf of the ARC and all of our partners for always being there for us and really giving us a clear view of what is going on in the pandemic as it relates to society and particularly our demographic, because we all know that oftentimes people with intellectual and developmental disabilities are not always prioritized, but Dr. Cherpes made sure that we understood all the health ramifications and ways to really advocate for our community. So thank you, Dr. Cherpes. You have lifted us up during some of the difficult times during this past 2 years.
Thank you, Sherry. Wow, that's a really nice introduction, and what a great way to start the day. I started with shoveling, actually, but this is a much better way to start the day. And please know that I recognize certainly that everything that I do is part of the team of ODP, and really couldn't do couldn't offer the support that we've been able to offer without a lot of great people. And really want to just start off before we get into the meat of the discussion with just a thank you to everybody who's on this call, and an appreciation for all that you have been willing to support, all that you've been willing to share, all the feedback that you've offered, and all of the days when you felt like you just couldn't do another day and you did. This is how we'll get through. We will get through this. I think that there's lots of nice evidence that we're seeing a slowdown right now for the case in new cases, and we will take our opportunities to recharge and re-energize ourselves every opportunity that we can. So as these cases begin to slow down a bit, please don't forget about your self-care and making sure you're taking good care of yourselves. Katie's I think going to help with the slide deck today. Want to pull that up. Thanks so much. We can go ahead on to the next one. So we're going to obviously be talking today about COVID-19 and its impact on individuals with disabilities. And we're going to really start pretty broadly, just talk about the grand scope of disabilities, focus in as we talk deeper into the presentation about intellectual and developmental disabilities and autism, but really wanted to kind of take that higher level approach so that we're all on the same page and kind of starting from the same point. We're going to review barriers to inclusion and participation experienced by folks with disabilities, discuss some of the healthcare access challenges, risks, the health risks specific for individuals with disabilities. I talk about some of the disparities in COVID-19 response. Then we want to get into some of the data, both nationally and for Pennsylvania. And finally, discuss mitigation efforts. Now, it's a really long list. I think that the presentation should still allow plenty of time for discussion at the end, and really we'll be looking forward to input not only about thoughts that or questions about the content, but additional thoughts that maybe we didn't discuss that we want to make sure that as a group we are keeping on the forefront as we move through this. And boy, what a year this has, a couple of years this has been. And I use the graphic there of a stethoscope with a coronavirus at the end of it, because really for healthcare, necessarily the COVID pandemic has been front and center, not only in the mitigation of the virus itself, but its impact on other areas of health. The pursuit of just general health and wellness has been affected for everybody. And as we talk later in the presentation about resilience and the impact of the pandemic itself, we can't lose sight of that it's far more than just the effects of exposure or risks of exposure to the virus itself. You can go ahead on to the next slide. Now, not news to anybody on this call, 1 in 4 adults in the United States is identified as having a disability, with disability being described as any condition of the body or mind that produces an impairment that makes it more difficult for the person with the condition to do certain activities and to interact with the world around them. And that's the definition provided by the Centers for Disease Control and Prevention, which I'll refer to here forward as CDC. You can go ahead on to the next slide. Now, from CDC data, we know that 12% of adults recognize as having a cognitive disability, almost 6% of adults hearing disability, almost 13% of adults have a mobility disability, 5% with a vision disability, 3.8% of adults with a self-care disability, and 7% of adults reported as identifying as having an independent living disability. Now, this was survey based by the CDC, so this was all self-reported information. And so now, and you could identify as having more than one of these disabilities. So these are not unique categories, but somebody could identify as having multiple disabilities. I'll point out that at the end of the slide deck, there is some references, but also as we go through, there are some links to references that I think will be helpful. On to the next slide. Now, again, not news to anybody on this call, but I wanted to just sort of highlight a fact that, so people with disabilities are a diverse group of individuals with a wide range of healthcare and support needs. Now, that at face value is obviously true, but the other thing that I want you to be thinking about as we talk, and one of the reasons why it has not been a simple task in really understanding the impact of coronavirus on individuals with disabilities is because, the broad diversity, there is not a single thing that is a unifying characteristic of everybody with even within subsets of disabilities, all individuals with cognitive disabilities have variability. And so we're talking about a world within these smaller worlds. And, I think it's really going to take years before we truly understand the sort of the biopsychosocial impacts of the coronavirus on individuals with disabilities for that reason and others. Go ahead on to the next slide. Now, pre-COVID, it has been identified that people with disabilities are more likely to report poorer health. That has just been a sad and disturbing fact of society. I mean, that has been the case. And I will say that while it's hard to say that there's a silver lining or benefit to the pandemic, what has changed, I think, on a national level is really the discussion about these disparities and health equity issues have really been magnified as a result of the pandemic. And hopefully that the momentum from the pandemic and the recognition that has occurred really can begin to move forward. And applause to this task group for your efforts in trying to make sure that this momentum is captured and persists, well beyond the risks of the pandemic itself. So almost 41% of folks with a disability report through self-rated health surveys as having either fair to poor health. And that's compared to just over 9% of people without a disability. So really a multifold difference in individuals' perceptions of health. Just again, this is even pre-pandemic. We head on to the next slide. Now, these statistics are all pretty telling. Almost 16% of people with a disability, and again, this is the broad definition of disability that we discussed earlier. Almost 16% of people with a disability have diabetes, and that's compared to just over 7% of those without a disability, so twice as many. 6.5% of people with a disability have had a stroke or a stroke-like event in the past year, as compared to just 1.5% of those without disability. A little over 13% of people with a disability have COPD, which is chronic obstructive pulmonary disease. I'm sorry, I should have not abbreviated that. Chronic obstructive pulmonary disease, a chronic lung condition where it's difficult to move air in and out of the lungs. So there's sort of a chronic level of under oxygenating the brain and the vital organs of the body. And that's compared to just a little over 3% of the general population without disability. 9% of people with disability have had cancer. And so almost twice as many compared to the general population of 5.3%. And look at this, just again, not necessarily surprised to us on this call, but always staggering nonetheless. 42% of individuals with a disability have experienced depression, compared to 11.6%, sometimes you hear 12% as the US statistic for adults with depression. So again, multi-factors go into this, but really all of these vulnerabilities existed previous to the pandemic and compounded the issues of dealing with and addressing the pandemic. We can go ahead on to the next slide. Now we're going to come back to this list a little bit later, but I wanted to point it out now because I think it's really telling, having just gone through those statistics. This is the list that the CDC developed to identify medical conditions that predispose individuals for more severe outcomes for COVID-19. So people that are more likely to have more severe impairment, more likely to have hospitalizations, and more likely to have death. Now, this list did change over time as sort of as more information was developed and understood. This list grew a little bit, but it was pretty clear early on in the pandemic, by mid to late spring even of 2020, these vulnerability groups were being identified. Now, I'm not going to read through the whole list, and we will go through this again a little bit later, but just wanted to point out that those bolded lists those bolded items there were the ones that we just covered. So every one of those areas where there is a significant level of disparity in the presentation with folks with disability versus without disability are all 5 key factors in conditions that enhance a person's risk for disease. So, and again, we're going to come back to this, but I just wanted to kind of have that in your minds, at having just gone through that list. So we can go ahead on to the next. I want to talk next about barriers to inclusion and participation. Again, sort of looking broadly at individuals with disabilities, not just specifically folks with intellectual and cognitive and developmental disabilities. So the World Health Organization, which are often here referred to as WHO, describes barriers as factors in a person's environment that, through their absence or presence, limit functioning and create disability. I think that last piece is really important, that it is often the barriers that are creating the problematic disabilities, and that if we can address the barriers, and oftentimes they are identifiable, which is the first step to addressing, we can really eliminate the limitations that a person who is identified as having a disability has in just sort of living their life, their everyday life, if you will. Can go ahead on to the next. Now, WHO categorizes the various barriers. And again, it's by naming and describing, we really can begin to break down and think about how do we address them. And hopefully at the end of the talk here, when we have a chance for some interactive dialogue, we're really interested in input from the group about thoughts about addressing some of these barriers. So attitudinal barriers really refer to the tendency for stereotyping, creating stigma or prejudice, or the existence of discrimination against those with disabilities. The ableism, of course, is a term that we hear a lot to sort of focus on abilities and discrimination against those with differing abilities. Communication is a key barrier, so experienced by people who have disabilities that affect hearing, speaking, reading, writing, and understanding. The Special Populations Unit of ODP really has been developed and has taken it as a charge in addressing barriers along this lines. And as we'll talk about later, communication barriers have been significant in access to healthcare for folks with intellectual and developmental disabilities throughout the course of the pandemic. Physical barriers themselves, of course, tend to be what we often think of as sort of the more obvious barriers. So obstacles that prevent access or block mobility, such as curbs and steps. But really, and the notion of equipment is going to come up several times as we're talking today, because it is such a significant barrier that I have experienced my entire career serving folks with disabilities in general, is making sure that the proper equipment is available to meet needs. And again, we'll talk about this a little bit later, but equipment necessarily must be designed with flexibility to meet the needs of a broad range of folks. And one of the common examples that we hear is, for mammograms, mammography, the equipment is really designed to work with an individual standing. And if a person has difficulty standing, really it is greater effort to create optimal results. But even things like scales, making sure that they have the capacity to weigh somebody on a wheelchair, that's not just sort of a specialty scale, but really needs to become the norm for scales in healthcare settings. Examination rooms really need to oftentimes be redesigned. Now, I will say, I think that there have been gains made in some of these areas, but again, clearly a long way to go. So, and then thinking about policy as kind of a general barrier. Examples CDC gives is sort of the lack of enforcement or awareness of the existing laws and regulations. Again, this is sort of from a global standpoint, and obviously, at ODP, always trying to refine and improve policy to make sure that needs are being addressed as necessary and to the very best extent to promote quality of life for individuals. I saw Jeremy Yale join the talk earlier. His lead as the Bureau Director for Policy really has, we're really very fortunate to have him with the team. I'll go ahead on to the next slide. Some additional barriers. So programmatic barriers, factors that limit the effective delivery of healthcare programs, such as inconvenient scheduling, limited sort of office hours scheduling, not access to later day scheduling or weekend scheduling, early morning, poor communication with patients. And that sort of really takes on a number of levels that, again, hopefully we can maybe have some time to talk about later, because it goes from the direct communication from the healthcare provider to the individual, all the way down to, what is the communication and that is conveyed at reception when a person comes into a healthcare setting that could potentially make them poised to be more receptive to healthcare opportunities. Also, though, that providers' attitude, knowledge, and understanding of people with disabilities can often be a significant barrier. And we're going to talk more about that actually in a little bit later in the talk. Really nice paper that we'll refer to. Transportation, I think, again, not a surprise to anybody on the call, but lack of adequate and accessible transportation can interfere and truly create a disability and impair a person's independence and participation in their life in the community. And then finally, social barriers. And we often hear this referred to in the term of social determinants of health, or those sort of societal factors that influence a person's overall health in the moment, as well as likelihood of health versus non-health situations in their lives moving forward. And this includes factors such as housing, or the lack of affordable housing, accessible housing, employment and the barrier of lower rates of employment, education, and income. And I want to focus just a little bit more and review a few statistics on employment and income for individuals with disabilities on the next slide. Now, from the 2018 American Community Survey, it was estimated that 37% of working age adults with disabilities are employed. 37%. Now that's compared to 76% of people who identify as not having disabilities. Almost 20% of people with disability have an income under $15,000 compared to just a little under 7% of individuals without disabilities. And when you think about $15,000 and how far that goes when you food, rent, and all of the sort of the basics of life, and then begin to think about the expenditures that you had personally in dealing with the pandemic, the masks that you bought, the hand sanitizers, the soaps, the disinfectant sprays, the newspapers and magazines and cable access to learn about information. You really can see how the income barrier becomes quite significant as we talk a little bit more about the pandemic itself in a bit. When people with disabilities are employed, they are more likely to work just on a part-time basis, 28%, compared to people without disabilities at 15%. And then finally, when you look at specifically intellectual and developmental disabilities, the statistics are even more grim. So for people with IDD, the disparity of employment participation is even greater. Data from the National Core Indicators Project suggests, and this data last reported was from 2017-2018, that only 18% of working age adults supported by state IDD agencies were employed in a paid job, and that's full-time or part-time, in a community setting. So really quite a significant barrier that we're discussing here. Go ahead on to the next slide. I'm going to shift gears a little bit. I'm just going to pause for like 10 seconds just to give your mind sort of a little bit of a breather break and just kind of soak that in. I know this is a lot of information. You will have the slide deck from today. It was not my intent to kind of overwhelm with numbers, but I wanted to make as much of this time that we had together and share as much information as possible. And really this so that you have this as reference as you are kind of planning moving forward. I think I'm hopeful that this will be a valuable reference. So when we're talking about access challenges and specifically access to healthcare challenges, people with disabilities have less access to adequate healthcare. Again, a known and disturbingly sad fact. And there are a number of reasons for this that, come into play. And as we think about solutions moving forward, we need to be thinking about in these various categories. One is the costs. Almost 27% of people with disability could not see a doctor due to cost within the past year, compared to 10% without a disability. Now, even 10% is a terrifying number. 1 in 10 individuals cannot pursue healthcare related to cost. And again, this is CDC reported data. So this is, not a disreputable source. This is, well-defined data, just really a significant number there. And then another issue that, has been, we've been aware of, again, my entire career has been dedicated, and spent on addressing and changing some of the stereotypes that exist within the healthcare provider community about disabilities. And this data is from a report that was done, and the reference is at the end of the slide deck here. I think it was released in February of last year, looking at healthcare attitudes regarding disabilities. And this statistic is just remarkable. 82.5% of US physicians that surveyed reported that people with significant disability have a worse quality of life than non-disabled people. Again, so this is 82% of the physicians who said this out loud, who thought that this is an okay thing to say, because unfortunately, one of the things that's true when you try to find out opinions and mindsets of individuals or professionals is that there's always the notion of what a person may truly believe and what they say out loud. And then, of course, there are the unintended or sort of less conscious ways of discrimination, sort of those inherent or implicit biases that we bring to all of our interactions. But this is sort of explicit bias, and really just an indication of how much more work there is to do yet, how much more outreach is necessary to really drive home the quality, the information and the notion about quality of life and the rich quality of life that everybody is capable of having, and that is not a ability versus disability determined factor. Only 56.5%, so just a little over half of the physicians surveyed agreed that they welcomed patients with disability into their practice. Just over half. And again, this is saying out loud. It's just really staggering, and something that we as a system need to continue to address. The federal, state, county, and community levels. Really, this needs to continue to have societal pressure to change and to correct. The lack of appropriate provider training is a significant access to significant challenge to access to healthcare. And I think probably related to that bullet above, that really better training sets the tone for understanding, more experience. If you spend even a 15-minute appointment with an individual with a disability to sort of begin to understand their quality of life and their ability to be supported through a traditional medical practice, that begins to change. So really, whether that's at the medical school level, or, maybe it needs to happen even earlier, but better training opportunities are clearly needed. And this lack of appropriate training poses an ongoing challenge. We see that almost 41% of physicians describe themselves as being very confident about their ability to provide the same quality of care to an individual with a disability as without. Sorry, I keep getting these pop-ups on my screen here. I'm just trying to X out of them. Okay, we can go ahead on to the next slide, please. So some additional challenges: lack of accessible medical facilities and equipment. Now, we talked about this earlier, just wanted to again highlight it because it is so important. So that exam tables and chairs might not be adjustable to accommodate a wide range of need. Scales, as I mentioned before, and just really needed to say again, because it's just something that's so simple and could be universally available, and yet still isn't. But scales to accommodate wheelchairs, or to accommodate folks that would have difficulty taking a step up to get on a scale and be stable on a scale. People with visual disabilities or intellectual and developmental disabilities, IDD, may not be able to access patient portals. I have trouble accessing patient portals sometimes, and even once in, sometimes the design is not as user-friendly as it could be. So that is just sort of a built-in unnecessary barrier that is created within the pursuit of healthcare. And everybody who's accessed the portals have really just appreciated how readily available and how convenient it is to be able to check something at 7 p.m. or because you haven't heard back from a provider, you can just sort of look in and see, did my results come back, or did they send me a message? And then communication barriers. Care after a medical visit may be hindered by my materials that are not available in plain language or in Braille, that the lack of availability of sign language interpreters or other communication supports to ensure that the message that was given during a healthcare visit was received. And because if it isn't received, it's not going to happen. You can get the best healthcare and all the right medications, but if you don't understand what to take or how to take it, you won't. But even more subtly than that, if you don't understand why to take it, if you don't understand the value and the connection between a condition and a response, the likelihood of compliance with medical treatment, and I don't use the word compliance as sort of following the rules, but really just the ability to carry out a medical plan that you intend to carry out, it is just unlikely to occur. So again, a significant barrier there. You can go ahead on to the next slide. Now, I want to talk next about COVID-19 specifically and people with disabilities. Now, we know unquestionably that people with disabilities have been differentially affected by the COVID-19 pandemic, and most likely because of three factors, and there may be other ones, and again, during the conversation, we'll look forward to the input, but three factors which we're going to look at in a little bit more depth include increased risk of poor health outcomes from the disease process itself. So just the higher risk of once becoming infected or becoming infected and the outcome. Reduced access to routine healthcare and rehabilitative services during the pandemic have influenced outcomes, and then the adverse social impacts of the efforts to mitigate the pandemic. Now, that'll be a little bit clearer what we mean by that as we get there. But first, I want to look more at the increased risk of poor outcomes from the disease itself. Next slide. Now, there have been a number of studies already that have looked at individuals with disabilities and outcomes of COVID-19. One of the first significant ones from the US was produced by the group in Syracuse, and that is referenced at the end of the talk, and identified that folks with intellectual and developmental disabilities were at higher risk for severe outcomes. I wanted to look in a little bit more depth, just, had to pick and choose here, but wanted to look in a little bit more depth at another study that was entitled "The Devastating Impact of COVID-19 on Individuals with Intellectual Disabilities in the United States." This was published in the New England Journal of Medicine. The link there will take you there. It's a great, very well written and easy to read article. A special shout out because it was produced here in Pennsylvania by the excellent healthcare group at Jefferson University. Really important and foundational work that not only validated the earlier reports that had been coming out, but expanded. And the study looked at 547 U.S. healthcare organizations, reviewed the records from over almost 550 healthcare organizations from across the country, and found that individuals with intellectual disabilities are at substantially increased risk of dying from COVID-19. And sort of, you may have seen this sort of a big quote from the study. I thought it was worth repeating, even if you had seen it, was that in this study, having an intellectual disability was the strongest independent risk factor for presenting with a COVID-19 diagnosis. So, the strongest risk factor for becoming infected in their review was an intellectual disability. And then the strongest independent risk factor other than age for COVID-19 mortality. So other than the over 65 age group, which was at the highest risk for mortality, right behind that was having an intellectual disability was the next highest independent risk factor for dying, for mortality. Head on to the next slide and talk a little bit more about some of the data that study produced. So patients with intellectual disabilities, had higher rates of COVID-19 incidence than those without intellectual disabilities and with COVID-19. So that was 3.1%, the incidence or the rate of the number of folks who had become infected with COVID-19 who had an intellectual disability versus 0.9%, so a little bit less than 1% in those without a disability, intellectual disability, who contracted COVID-19. Patients with intellectual disabilities were more likely to be admitted to the hospital if diagnosed, so 63% versus 29% of those without an intellectual disability. Persons with intellectual disabilities who were diagnosed with COVID-19 had higher rates of ICU stay. Again, more than twice, 14.5% versus 6.3%. And finally, we're more likely to die following the diagnosis of COVID-19, 8.2% in their reviews versus 3.8% of folks with COVID-19 without intellectual disabilities. So more likely to catch COVID-19, more likely to end up in the hospital with COVID-19, more likely to end up in the ICU if you made it into the hospital with COVID-19, and more likely to die. So really on all four fronts, a higher risk associated with intellectual disabilities for COVID-19. Now, mind you, important, I should have mentioned before, this study was all pre-vaccine. This came out prior to vaccine availability. So obviously, we know that vaccine was a huge saving grace, a huge weapon in the fight against the pandemic and in the ability to preserve life. And we'll talk about that because even the vaccine itself has been fraught with some access challenges. But just wanted to point out that this information is pre-vaccine. Go ahead on to the next slide. So again, from the study, individuals with intellectual disabilities were less likely to be in a higher age group. So more likely that when they were infected, it was younger folks compared to the general population, which had higher risk for older folks. They were more likely to have a healthcare payer status associated with a lower socioeconomic status. So one way of sort of looking at socioeconomic background is looking at the payer status of the healthcare, and so smaller percentages of private healthcare in folks with intellectual disabilities. And finally, folks with intellectual disabilities had higher rates of all comorbidities other than cancer that they looked at prior to the study. So this study, again, looked not only at the presence of COVID-19 intellectual disability or not COVID-19, no intellectual disability, but a number of additional comorbidities or healthcare conditions that were present prior to the diagnosis of COVID-19. The next slide, we're going to look again at that list of the conditions that had higher risk for severe outcomes. We can go ahead on to the next slide. So this is that same list as before, and all of the bolded items on the list were items that the study from Jefferson looked at as potential comorbidities. And all of these conditions, every single one except cancer, had higher incidence in folks with intellectual disabilities than in the non-ID population. Every one of those bolded items, so kidney disease, liver disease, lung disease, dementia or other neurologic conditions, diabetes, heart conditions, obesity, stroke. They also looked at a few other conditions that weren't on the CDC's list for risk for higher severity. That included thyroid conditions, malnutrition, electrolyte and fluid imbalance, and anemia. And again, all of those also had higher incidence in individuals with intellectual disabilities. So this health disparity is just really glaring at us right here in such a potent way of what we need to do and how we need to support folks to address these basic fundamental components of a everyday life to let alone how do you get through a pandemic, but just these are all barriers to a healthy life in the community. Go ahead on to the next slide. So again, the first factor when we're talking about COVID-19 and folks with disabilities is that risk for poor outcomes from the disease itself. We just sort of spent the last few slides talking about that first bullet, but the second point here, I don't want to lose either. The psychological distress experienced by the disabilities community due to activity restrictions has really been recognized as having an impact on mental health. And the study that I have referenced here, which is available through the NIH website, in that link below, really emphasized that individuals with autism particularly seem to be have impact from the activity restrictions and routine restrictions. Again, not necessarily surprising, but as we think about addressing responses in the future, something that we just need to keep in the forefront. You can go on to the next slide. So the next items of the three that we're talking about, so more severe outcome due to the disease itself. Then second was reduced access to routine healthcare and rehabilitation during the course of the pandemic. Now, we all know that telehealth was I think miracle is probably a too strong a word, but a truly life-saving intervention for this nation when face-to-face care was associated with a significant risk of infection itself. So the use of healthcare really for some was such a wonderful opportunity, but for many others, it really provided challenges to receiving good quality healthcare. Individuals blind or low vision, screen reader tools not necessarily compatible with telehealth technologies used by healthcare providers. The tools, some were easy to navigate, some were not. And folks with cognitive disabilities, and frankly without cognitive disabilities, some of the tools just were not very user friendly. Folks who are deaf or hard of hearing may or may not have, oftentimes did not have adequate access to interpreters, American Sign Language interpreters, or closed captioning, or sort of spontaneous captioning that is available now through many of the video platforms. So really, there were a number of challenges, and due to those challenges, the workarounds may have resulted in less effective quality care. Caregivers themselves, individuals had a disruption in access to caregivers, whether that be family members or other natural caregivers or even paid caregivers. This was a disrupted level of access. The lack of resources that were available, again, nationally to support family caregivers played a role in the impact that this pandemic had on individuals with disabilities, and particularly intellectual and developmental disabilities. And interventions, so typical interventions, including mental health treatment, school-based supports, they just weren't implemented or able to be implemented as effectively due to reduced in-person work. And there were areas that had more and less success with these sort of virtual supports. So all in all, healthcare access itself was impaired, and rehabilitative supports were of a different and oftentimes, again, nationally lesser quality as a result of the pandemic. And then finally, the third aspect on the next slide, the adverse social impacts of the efforts to mitigate the pandemic. So, unemployment, right off the bat, it was necessary because of the way that the pandemic was poised to spread, overwhelm the healthcare system, lead to even more deaths, then the United States has been the leader in mortality in the pandemic. It would have been even worse if there hadn't been sort of the shutdown and the loss of employment for many. But nonetheless, it was a significant impairing event, and folks with disabilities were disproportionately affected. 1 in 5 workers with a disability became unemployed versus 1 in 7 workers in the general population due to the loss of jobs. And that statistic is looking by August of 2020, when 1 million US workers with disabilities had lost jobs. And then unmet needs. So for some, the pandemic impacted transportation options and reduced access to medications, food, and basic necessities. Now, again, obviously, everybody on this call, everybody I work with, did everything that they could to try to make sure that was not the case. But we know that nationally, again, there just were times when it was the case, and being the case, couldn't help but affect a person's healthcare during the pandemic. And then also the home and community-based service providers did not receive the level of federal pandemic assistance that was made available to other healthcare providers. Again, just a truth that there was in general more support that was available for the hospital system as compared to home and community-based service providers. And at least half of the states saw a permanent closure of health and community-based home and community-based service providers. Go ahead on to the next slide. So now some of the reasons for disparities in the COVID-19 response are sort of rooted in a lack of data. There's the saying that who gets counted is who counts, or who counts are those who are counted. And the ways in which data has been gathered nationally has influenced our understanding of the pandemic. And I think it sort of identified that early on. In particular, those with disabilities weren't as included in the understanding and sort of comprehension of the data, that the early, again, particularly early estimates of COVID-19 cases and deaths focus on nursing homes. And nursing home data really reflects just a fraction of the population with disabilities. So an area there. Data collection, as we talk about, is a fundamental pillar of public health, and the lack of information perpetuates social injustice. So the need for more robust data really is strongly indicated. Not only more data, but making sure that the data is accurate, and that inaccurate data on COVID-19 and vaccine rates can influence unknowingly public health care decisions. And so if the data isn't accurate, then the best determinations to eliminate disparities can't be made. And in fact, unintentionally is propagating and perpetuating disparities. Go ahead on to the next slide. Issues with accessibility of testing and vaccination really contributed to disparities in the COVID-19 response. A lot of the testing occurred in these sort of stand-up and drive-through testing sites. Really high throughput, trying to minimize exposure as much as possible. Again, primarily pre-vaccine, but even since. So for some who don't have who can't drive, have trouble sitting in a car, really access to testing was problematic. Vaccine registration websites, are known. Some have not recognized disability right laws and creating inequity for folks with disabilities. Again, it's a national information. States and territories varied in vaccine prioritization for the disabilities community. This is something that, again, we know firsthand that in different locations, different states, there were different levels of access when those initial priority lists that were generated, and it was really at times not within the state, but with the state being able to be recognized on a national level, fighting very hard to make sure that folks with disabilities and caregivers of folks with disabilities were sort of recognized as that sort of first wave of healthcare, of the healthcare system that really needed to be part of the prioritization for vaccination. You want to go ahead on to the next one? Obstacles to accessing information on the pandemic. Again, it's a lack of captions or alternative text, difficult to find information relevant to a variety of conditions. Google searches sometimes are simple, sometimes not. Overwhelming and confusing information. I think all of us sort of have dealt with the overwhelming and confusing information. And part of it is because just the information has been evolving and therefore confusing. And sometimes it was the way in which it was presented that was the confusing part. When we talk about some of the mitigation efforts a bit later, that was one of the things that we did try to address to help reduce some of that disparity. Go on to the next slide. I'm going to look next at some of the ODP COVID-19 data to put it in context of everything that we've been talking about. Now, this slide here is data that was publicly released back in November. And so this particular slide date just goes through the end of October. So the total population of individuals registered with ODP during the fiscal year 2021 was 55,500. As of 10/29, 6,161 individuals supported had tested positive for COVID-19, and from March 2020 through the end of October 2021, 285 registered individuals registered with ODP had died with confirmed results of COVID-19, and an additional 44, again, this was at the time, deaths where the final cause was still pending, but suspected to be COVID-19 related. Go ahead to the next slide. This is the breakdown of those deaths by age range. And I'll just mention that the 10 to, no, it says 0 to 10, but it should say 10 to 19 age range, and the 90 to 99 age range is marked at 5 there, but actually represent 5 or less. So we use a determination of 5 or less when there are smaller numbers, but you can sort of see that as kind of a bell-shaped curve of the age breakdown for deaths. Go ahead on to the next slide. And then this data is all available on the DHS website, looking at ODP licensed facilities from the start of the pandemic to, I pulled these particular data sets yesterday, so they are up to date. Individuals, so this is for individuals in licensed facilities, so community homes for individuals, as well as life sharing homes. 3,800 individuals tested positive. 170 individuals receiving services had died, and staff serving in those locations, 7,600 had tested positive. Go ahead on to the next slide. For ICFs, for persons with intellectual disabilities, so this is data for the private ICFs, not the state centers, which we'll talk about next. 703 individuals had tested positive for COVID-19, 40 of those individuals died, and of the staff, 1,320 had tested positive for COVID-19 from March through the beginning of this year. The state-operated facilities. Of course, there are 4 state-operated facilities: Ebensburg, Polk, Selinsgrove, and Whitehaven. I won't sort of read through this whole chart here, but you can sort of see that the first column is the census of each of those sites. The current number, again, as of yesterday, who've tested positive for COVID-19, the cumulative number, the number of deaths, and again, with less than 5, it's just listed as less than 5. Over 5, it's listed the specific number. So the highest number of deaths here, as you'll see, occurred at Whitehaven Center, and then the other 3 centers all had less than 5. And then the number of current staff, as well as the current positives and cumulative positives among staff. You can see really heavy disease burden had been incurred over the course of the pandemic for all of these locations. Go ahead on to the next slide. And then finally, the last look at the data is with an analysis of Medicaid data that was performed by the University of Pittsburgh on behalf of DHS. So they analyzed Medicaid data to look at the burden of COVID-19 among the Pennsylvania Medicaid enrollees, including those with intellectual and developmental disabilities and autism spectrum disorder. They explored through this analysis associations between IDD, autism, and COVID-19 related to the diagnosis of COVID-19, hospitalizations, and deaths. So sort of mirroring what had been done with those larger national studies that we already have talked about. And then the enrollees were further stratified or broken down based on whether they were receiving long-term care or living in the community. I will say, every study has limitations, and part of this limitation was that long-term care meant primarily nursing home. There is possibility that there were some folks who were in, I think somebody's mic might be open. Possibility that there are folks who were in private ICFs that were included, but the majority is going to be nursing home data. And so in this cohort of over 1 million enrollees over the age of 20, 2.4% or 33,000 were receiving long-term care, and the rest were folks living in the community. And the community, I'll point out too, did not distinguish between what the setting in the community was. So it was either long-term care, primarily nursing home, or the community, which could have been a private home, it could have been a group home, it could have been a personal care, assisted living residence. So again, limitation in the study, but we'll see on the next slide, really primarily that it was confirmatory for what the other studies had seen. About 12% of the enrollees in the long-term care group were diagnosed with IDD, as compared to 3.2% in the community. Folks with IDD in long-term care settings had significantly lower, interestingly, unadjusted rates. So not looking at any other factors than just the factor of, they have an IDD, they're in long-term care setting, and they had COVID. No other sort of contributing factors is what they describe as the unadjusted rates. So slightly lower rates of those who were diagnosed with COVID-19, hospitalized with COVID-19, and died from COVID-19. Now, in contrast, folks with IDD receiving Medicaid in the community had significantly higher unadjusted rates for all 3 of those measures of diagnosis, hospitalization, and death, as compared to other community enrollees. Next slide. After controlling for the demographic and other healthcare variables, the enrollees in the community were significantly more likely to be diagnosed, hospitalized, and die with COVID-19 relative to other community members. So very much reflecting what the Jefferson study had shown. And then in the long-term care setting, folks with IDD were less likely to be diagnosed with COVID-19, but those who became infected were more likely to be hospitalized than other long-term care Medicaid recipient enrollees. Go ahead on to the next slide. And finally, looking at individuals with autism, there was a relatively small sample size, so it's hard to draw much from it, but between 1% and 2% of enrollees in long-term care and the community groups were diagnosed with autism. Unadjusted rates of COVID-19 diagnoses, hospitalization, and deaths were relatively low in general, and maybe because of that, but there just was not any statistical difference seen in folks with autism and whether or not they had diagnosis, hospitalization, or death. But again, because of the sample size, it's hard to really know what to make of that data, but that's what was reported. And again, this has not been published data. It's preliminary, but it was I just wanted to share some of those findings. And then I just want to talk just very briefly on the next few slides about some of the mitigation efforts, and then we'll open it up to a broader discussion. We talked about access to vaccine as being at issue, and in particular, navigating some of the governmental websites to reach vaccine, and particularly when vaccine was much more scarce, it was sort of very confusing as to how you got onto lists, and when you were going to get callbacks, and when you were going to get emails, and if you were going to get a callback. So one of the things that ODP did to make sure that folks who maybe had more difficulty navigating the virtual system had a live person to be able to reach. And ODP through DHS, we established a call center for individuals with IDD and autism and their families to be able to access vaccine to help sort of mitigate one of those barriers. And that operated from April to June of 2021. Subsequent to that, really the availability of vaccine became much more prevalent, and this level of intervention wasn't necessary. It was supported through a partnership with Rite Aid, and again, sort of creating partnerships with an industry member, a pharmacy, really was such an effective way at addressing and eliminating some of the barriers that we had experienced, that we all had experienced. And just a few other things we'll go through very quickly. On the next slide, Aid in PA was a website that we started early in the pandemic to make sure that information was able to be presented in formats that was accessible from a communication standpoint, as well as from a content standpoint, and it was designed for individuals, for family members, as well as content for direct support professionals all the way through healthcare professionals. And that was made possible through the collaboration between ODP, the healthcare quality units, and ASSERT, the Autism Services Education, Resource, and Training. On the next slide, just that's the website access, if anybody was not unfamiliar and needed to reach out to a healthcare quality unit or ASSERT. And I think just one more slide here. Oh, maybe a couple more. Also, early in the pandemic, set up a statewide support and referral helpline. So sort of a live line where people could call if they were having struggles related to the pandemic, particularly emotional struggles. This is still in effect, and so it's still an accessible number. The folks that supported this line have experience in supporting folks with intellectual and developmental disabilities. So it is not specifically for folks with IDD or specifically disabilities in general, but they are experienced in support. So, it's really a truly inclusive line. The importance of receiving reputable, reliable information can't be overstated. And, the CDC, Pennsylvania Department of Health, were really our primary, ODP's primary sources for information that we shared with everybody. We took back your information and shared it with these partners as well. And then finally, just a few additional hot link references on that, I think is the very last slide. To refer to. I'll point out that, which one here is it? The second one, the disability, health equity, and COVID-19. That is NIHCM. It's an organization that seems to be primarily from Anthem Insurance, but really it's a beautiful site, beautiful infographics. Sort of the structure of this talk drew heavily from the layout of that site. I really liked it. I wasn't familiar with the organization prior, but I just wanted to point that one out and just compliment them on their ability to present clear information.
Thank you, Dr. Cherpes. That was quite a comprehensive report, and you can take a drink of water now. I mean, I'm sure you're.
I'm going to go on mute so I don't slurp, but yeah, I just need to wet my whistle here.
I'd like to point out that when the ARC of Pennsylvania was approached by the Department of Health to work on this health disparity grant, we were very quick to point out to the Department of Health that health disparity existed in the disability community, way before the pandemic came along. So the work that we're doing on this is obviously through Dr. Cherpes' presentation is much needed. Pre, post, and whatever the world brings us the next time around, whether it's a pandemic, a natural disaster, or just regular healthcare. And I think that is our overarching goal with this grant, is not just to discuss the health disparities around COVID-19, but to really build those bridges between the healthcare provider organizations about access to care, as well as, teaching practitioners the way to interact with our community as well. I was just told a story this week by a person who has a disability and uses a wheelchair, and he could not get an eye appointment. He could not get an eye exam because they wanted him to transition to their chair, and he cannot. And he, it was really just, it really takes our breath away. What we take for granted as a simple eye exam cannot be done. And Dr. Cherpes pointed out several other examples. So I am going to open it up for questions. Katie, would you prefer, well, actually, I'm going to let people choose. If you would prefer, if it's easier for you to type in the chat, please do so. I would ask that since we have such a large group today, if you're able to use the hand, the raising of the hand in the Zoom box, to use that. Or if you're not and you just want to wave your hand, and we can open your mic then.
I see Matt Ahrens has raised his hand. Matt?
Hello, good morning, everybody. Can you hear me? Wonderful, thank you. Well, that was a wonderful presentation with lots and lots of great data, so thank you very much. The study that you mentioned during your presentation that was conducted by the team from Jefferson, two of the authors of that study recently published an op-ed where they were advocating for access for people with ID to therapeutics, COVID therapeutics, the drugs that are emerging. And they were saying that the challenge was not so much prioritization or inability, but rather education and awareness in the medical community. I wondered if you had any thoughts on that, and could comment about whether the state, whether ODP or other agencies are addressing that issue.
That is a great question and comment, and really pointed out an additional slide that should have been in this presentation, because you're right that access to the therapeutics is fraught with potential barriers and challenges as well, not for distribution or prioritization, as you point out, but just the level of awareness. We worked hard early in the course of the pandemic to make sure that the state centers were all sort of savvy and aware of the availability of monoclonal antibodies, which at that point needed to be done on an IV infusion basis. But there are alternatives now for delivery. But likewise, in the general community, we, ODP, I think at least twice, distributed information through the listservs about therapeutic interventions available for COVID-19. So really, particularly in community-based care, making sure that individuals, families, provider organizations knew to ask, because that, I think, was a big piece of it, partly because of some of those physician and healthcare provider biases that people with IDD or other disabilities maybe don't come to mind first, that we're going to do this additional sort of level of intervention. So, and I don't think it's intentional exclusion. I think it is, all of those other reasons that we talked about. So we really thought promoting awareness, and clearly we need to do some more, and we will certainly can revisit that topic, but that's a great point. And that will include the oral antiviral as well, and then the oral monoclonal that will be available too. Thank you.
I want to recognize Deputy Secretary Kristen Ahrens has joined us today. So Kristen, I don't know if you want to just say a word or two or three. Don't want to put you on the spot either, but thanks for joining us.
Yeah, I had obviously a meeting that conflicted. I would have enjoyed being part of the discussion earlier, but I just for all of the reasons that I think are obvious, this conversation is so important, and timing is really interesting here. I do feel like there's a little bit more attention in places that matter in terms of these questions of bias and how strong our continuity of operations are in our health systems and our hospital systems. I actually will leave here at 10:30. I was asked to do a podcast on IDD for the Association for State and Territory Public Health Officials. So this is, I think these are nice indicators that, it took this. For me, I think this pandemic is a little bit of how Katrina was for natural disasters, and our awareness of how ill-prepared our communities were to support people with functional needs, people with IDD and disabilities in natural disasters. I am hopeful this pandemic is certainly raising the level of awareness, and is sort of that parallel moment, and that we can, that the kind of work that's being done through this grant and this project continues, that this moment we actually are able to really capture it and use it to promote some real health equity and start addressing the kind of bias that I think means we have poor care in some cases. So glad I could join you. Sorry I had to be late.
No, thanks, Kristen. Maria.
Maria, if you want to unmute, you can ask your question.
Katie, can you see if you can unmute Maria?
I can ask her to, but I can't unmute her. There we go. Hi, Maria.
I have a comment about the person who went to the eye doctor. I just see eye doctor and I get examined for my wheelchair.
Maria, can you repeat that? Are you,
Yeah, I get my eye exam sometimes for my wheelchair.
So Maria, I think you were saying, and correct me if I'm wrong, that you've had issues with your healthcare professionals because of your wheelchair.
No, I can get my eye exam for my wheelchair.
Sorry, I was on mute. Maria, were you saying that you were able to get your eye exam from your wheelchair?
Yes,
I'm really happy to hear that. Of course, that's how it should be, and we're all working hard to make sure that that's the case. That the medical equipment that's being designed and being purchased by practices, it has the flexibility to meet people where they are.
Yeah, but I don't have any with me to lift me up if they want me to be lifted. But I have it done. Yes,
I'm glad that was your experience, that you were able to get a good exam in your chair.
thank you.
Thank you for sharing that.
You're welcome.
Mike, you were next.
yeah, go ahead.
Did you say me, Katie? All right, thank you very much. I'm Mike Greer. I'm with the Pennsylvania Council on Independent Living. Doctor, for the comprehensive presentation, it was excellent. But I did want to ask you about a couple things. We've known that the discrimination that you talked about in going to just regular healthcare facilities and going on for people with disability for
it's
years.
just slightly snowy, but I'm on a webinar right now, so I can't really talk.
Oh,
All right, bye.
I'm really sorry. Can we all please make sure that we are muted unless we are asking Dr. Cherpes the question? Sorry, Mike, please proceed.
No, that's okay. The couple questions I have is, do you believe that the healthcare industry in general has a leaning towards institutional bias, that you have to put people in congregate settings to be able to treat them? And we saw the results of some of that on the negative side during this pandemic. And the second one is, if that is the case, that we believe this, how do we address it with the overall general healthcare? Thank you very much.
Yeah, thanks for asking that question, Mike. It's nice to meet you. So I guess my honest opinion is that, from a healthcare provider standpoint, I think that isn't necessarily where the bias is. I don't think it's that people, healthcare settings, and I've worked in a number of different ones where it was, and supporting folks with intellectual and developmental disabilities, and I hadn't really ever experienced the notion that the healthcare system itself shouldn't be the place for care. I think it's really the institutional bias is more about meeting the needs of the average person rather than the diversity of people. And I think that's changing. I think that it's not caught up to where it needs to be. And, these statistics really pointed out why it matters so much, that it's not just merely about, and it should have been enough that it's about, quality of care, quality of life, but the resilience and the ability to meet new challenges from a physical health threat standpoint. Were just so blatant that all of these sort of struggles or challenges to fighting an infection, every one of those things on that medical healthcare risk list, really we were at a disadvantage in this community from the get-go. And so what we do moving forward really has to be so focused on not only healthcare, but wellness in general for folks. And I'm not sure if that fully answers your question. And I don't know if I can think of data sources to look at that notion of bias. But I think that, again, my experience hasn't been that has specifically been the problem.
Okay, thank you.
You bet. Thank you.
Before I move to the next individual that had their hand up, I do just want to acknowledge a thing that came into the chat from Matt Ahrens, a comment. He said, thank you for answering the question. And if Special Olympics can be able to partner in helping to increase awareness, they are willing to do so.
Thank you.
Next on the list is Sally Joe.
All right. Hey, and I'm just going to quickly dovetail too. I had responded to Matt's comment in the chat as well. Matt, and we can even chat somehow, but here in the Wild Wild West, Andrew Fee, who works with Special Olympics and has been outstanding, we're actually holding a listening session Monday night, January 31 at 6:30 to hear the stories of the athletes. So encourage with whatever part of our big Commonwealth you're from to do the same. And on that piece, Doctor, thank you for your presentation, the information, and for who you are and the work you do. I think, and it kind of is playing off the previous comment, the comment that struck me right out of the gate, and I wrote it down and circled it, was, and yet still isn't. And yet still isn't. That has been what, in my experience working in this field, as well as in the many listening sessions we're holding, is these continual barriers of what Maria shared, and kudos to Maria, a great self-advocate, of, you know, not being able to get an eye exam, the number of times not being able to access the website to even get registered to get a vaccine. I mean, I could go on and on. So suggestions, points, guides, game plans on how we get from, and yet it still isn't, to, and finally it is.
Yeah, that's, you know, there's not an easy answer to that, other than it just needs to keep happening. You know, I can share a personal example. You know, I had worked previously at the Center for Prader-Willi syndrome, and you know, so this was an established national program dealing with the needs of folks with intellectual disabilities, physical health challenges, including severe and morbid obesity, and yet changes needed to happen during the course of my time there to make it more accommodating for the people that it was designed to serve. And it meant sort of, you know, doing independent fundraising and just really spending resources to make sure that those necessary equipment made people not only be able to be treated, but to feel welcome and to have, you know, the capacity to be in a room that they not only know is going to support them, but also help keep them safe. And, you know, I think that there's so many opportunities that we all have to look, you know, locally and continue to do sort of a more global outreach about it. Thank you.
Thank you. I do want to do a last call for questions here. We are getting close to end of time.
I think there's
Shane,
Shane.
Shane, yes.
Hi, everybody. I'm Shane. I'm the executive director at the ARC of Philadelphia. Yeah, thank you for everything. I actually just wanted to put out there that our chapter, we've had a health advocacy program going on, I think 5-6 years now, before I even had began here. And to Matt Aaron's point about just that op-ed as well on one of the systemic barriers of just getting future healthcare professionals the experience of just interacting with this population to alleviate those biases. We do that here out of Philadelphia, and we feel like we're positioned, Philadelphia being a hub of some of the world-renowned medical systems, as well as UPMC out in Pittsburgh. So I think our state is positioned in a way to be a model for other states if we want to look at some of the state policies around requiring these trainings. And that's the biggest barrier that I see in all the advocacy work, is that the organizations that take on a required training to serve people with ID, the universities that we're involved with are also, choosing to have these programs, choosing to have these internships, volunteerships, field work for their future healthcare professionals. in medical school, dental school, rehabilitation sciences, nursing schools, you name it. And that's one of the barriers, is that there aren't these requirements that come down. And I understand that those come from the accrediting bodies for those degree programs nationally. But if there are ways to think about what state policies we can put in place for maybe the healthcare networks, things like that, we would love to advocate at the state level for those pieces. And then, yeah, just again, we partnered with Special Olympics as well in some of their health advocacy pieces, and our chapter is in a really strong position with what we've accomplished in the last 5 years or so. So we just want to be an asset and a resource for everybody that wants to get involved in this space with us.
That's so great to hear, and thank you for all of those efforts that are so important. And, I think, it's a sign of passing, into the later stage of middle age that I think that young people are changing. But I think that medical students now have a greater capacity to receive this sort of information and are expressing more interest in getting information about serving a more diverse humanity. So I think that we have the opportunity to capitalize on some just cultural and societal changes, and I hope that we're able to. Also, you mentioned the two sides of the state. I also wanted to just give a shout out to the Northeast Healthcare Quality Unit and their work with the the Commonwealth Medical School, the Geisinger's Medical School, now in doing educational experiences for doctors in training, for medical students, for working with folks with intellectual disabilities, and doing special projects like looking at polypharmacy. So I think there's lots of opportunities in all of the educational centers, and thanks for those efforts in Philadelphia. And I look forward to, we should probably talk more about some additional things that we could think of.
Well, we have reached our time limit. Actually, we're 3 minutes over, and we so appreciate Dr. Cherpes' time and great conversation, great comments. So I want to wish everyone a wonderful weekend. You will be hearing more about this subject through the work of this Health Disparities Grant. And I think everyone, I don't want everyone to walk away saying, oh, we've got such a heavy load. I think the future looks bright. If we have to look at one positive outcome, maybe of this pandemic is, we knew health disparity existed before. It's here, but now we have that opportunity to really make the change. And I think that, like Dr. Cherpes said about the younger population, medical students or practitioners, this is the time for change. And we are certainly, through this work, through all of you and all of the work that you're doing, we will hopefully be that momentum for change. So I want to thank everyone. I'm going to ask that the grant team stay on for 5 minutes, and wish everyone a wonderful weekend. And thank you again for joining us today.
Thanks, everybody. Stay safe.